Excellent. Thank you very much. We're going to try to move quickly today on complementary and alternative medications, and they are different. Complementary is using non-mainstream approach together with conventional therapies, whereas an alternative approach is using them in place of a conventional source of medicine. I think we would all agree that most of us are open to complementary medication, but typically object to the use of these alternatively, particularly if it's going to delay established and available treatments. There was actually a survey done of GI docs with an interest in IBD, which showed that 1/3 initiated conversations on complementary alternative medications in the majority of their patient interactions. Most had recommended the use of probiotics, and nearly half of these physicians had recommended the use of acupuncture, and the majority believed that there was an adjunctive role for the use of CAM. So what's the issue? Why aren't we sort of recommending these more, discussing these more? What are the barriers to acceptance? One, there's very few controlled studies. We'll show you a few of them today. Small sample sizes, even when there are trials done. There's typically methodologic concerns and lack of adequate blinding. The data tends to be weak even when it's positive, and oftentimes even after a positive study, there's very few or no follow-up studies performed. When you're looking at a study on CAM, it's important to look at whether the medication or whether the complementary alternative is used as an alternative or complementary, and who are they doing this in? Is this UC? Is it Crohn's? Is it mild disease, moderate, and typically less likely to be severe? This is not uncommon, so we all have to think about it with every patient encounter. Doesn't matter where you're from in the world. About half the patients are using CAM, and about half of them are not disclosing it. So I ask all my patients at every visit whether they're using other medications, over the counter, under the counter, however it works. And it appears to be becoming more and more common. The last study was about 5 years apart, 2 French studies. You can see the numbers going up. And most patients, if asked, are interested in learning more about potential CAM. So why do patients use them? There's various reasons. You can see the long list there. Oftentimes it has to do with dissatisfaction or potential side effects to conventional therapies. What are the different subgroups? You can see them here. Most often it's natural products, herbs, vitamins. I'll throw cannabis under there. We'll touch on a lot of these today. We're not going to touch on FMT today. Probably less CAM than true therapy at some point. So this is what a lot of your patients would like. I guarantee it. I've already heard about it today even before coming up. And this is certainly what your patients, a lot of them would like to be seeing at home. So cannabis, I'm going to focus my part here before handing off. It's been used for over 2,700 years. It typically comes from the bud of the female flowering plant. It's 500 different chemical compounds. The two most important ones for purposes here are THC, which is the psychotropic compounds that most of the people interested are looking forward to, and CBD, or cannabidiol. There's 2 different main types of cannabis, sativa and indica. Sativa has the highest THC to CBD ratio, whereas the indica has a higher CBD ratio. It's not uncommon, like I said. This is old data from 2009, and it's increasing. And when you look at patients with Crohn's disease, it's pretty high IBD as well. So what about it? There's very little clinical evidence that it's effective in treating any disease, let alone IBD. Most of the controlled trials actually relate to synthetic cannabinoids and not medical marijuana. There have been a handful of studies in GI and a couple in Crohn's disease, and those are the ones I'm going to touch on today. Again, this is bringing together a number of different studies. About 50% of patients admit to marijuana use, and up to half of them use it to control symptoms of IBD. A third of patients say it works better than steroids. And there were 2 small studies I won't go into that they were observational. They suggested improvement in symptoms and quality of life. And there is some science behind it. Animal models suggest, and a few human studies suggest it can slow GI motility, decrease abdominal pain, visceral hyperalgesia, and even some evidence that it has anti-inflammatory properties. So this is the RCT. This is the reason most people hear about it. This was a small Israeli study including patients with Crohn's disease, with active disease, failed at least 1 therapy. A lot of them had just been mesalamine. They were randomized to either a cigarette with THC or a cigarette in which the THC was removed. The primary endpoint was remission, or CDAI, less than 150. Here are the outcomes. You can see from the remission rates were no different between the 2 groups as far as your p-value is concerned on the top. They did see a higher clinical response or drop in the CDAI by 100 in the group that was randomized to get the cigarette with marijuana, and there were improvements in quality of life. So what are the issues? They missed their primary endpoint. There was no improvement when they looked at CRP, so no objective evidence of it improving inflammation. And 19 out of the 21 patients were able to tell what group they were in, basically unblinding the trial, right? The big question is, who are those 2 patients that couldn't tell what group they were in? There's something wrong with those 2. So before sort of handing this out and, you know, writing with your little marijuana pen, I think more studies are needed, that we need proof it's effective for Crohn's disease, and specifically that it improves the inflammation associated with Crohn's disease. This study I literally just pulled out and added a couple of days ago. This is another Israeli study, so clearly the Israelis have more marijuana than we do here. Again, small study, Crohn's disease activity index greater than 200. They were randomized to oral CBD, and again, this is in pill form, droplet form versus placebo for 8 weeks. Primary outcome was a decrease in the Crohn's disease activity index by 70. There was no difference in the delta CDAI between the 2 groups. You can see both groups dropped. A few patients in each group were able to reach remission. There were no changes in some of the laboratory values that were checked, but again, no difference in CRP. So another thing where they said, although it didn't appear to be effective, maybe it was too low a dose, nonetheless, no difference in adverse events. So what are the issues? Why can't we just dole it out? Labeling and testing is not standardized like most of the stuff we're going to talk about today. There are risks, right? This isn't without risks, and that's something we have to think about. It may worsen the prognosis. There was a Canadian study that suggested marijuana may be associated with a higher risk of surgery in Crohn's disease, similar to tobacco smoking. It can mask signs and symptoms, sort of like narcotics, which we know are associated with a higher risk of serious adverse events in patients with Crohn's disease. And then there's the acute and chronic effects. Acute, you know, basically you're stoned, don't drive, you get dizzy, nausea, fatigue, you get hungry, you're going to weight gain. And then there are long-term effects on memory, cognition, has cardiovascular events as well. Unclear if it really increases the risk of lung cancer or other cancers, but there's enough saying that going against it. What are the relative or contraindications? Again, this is based on synthetic cannabinoids, serious cardiovascular disease, serious psychiatric disease, kids, pregnancy, as you'll hear later. And again, for us, the medical status is, its legal status is that it's illegal, basically, from the, you know, our government, and it makes us nervous. It's Schedule 1, which means no medical use and high potential for abuse. Again, briefly, it was first legalized medical in California back in 1996. Now, if you look it up, there's 28 states that have legalized the possession of medical marijuana, and half the states, Crohn's is a qualifying condition. 7 of the states, it can be used for recreational use, including Massachusetts, as my friends are happy about, and decriminalized in 20 states. Most people actually think it should be medically available for patients who will benefit. But again, to date, there's been no change in the federal law, which still prohibits possession and sale of marijuana. Physicians haven't been gone after yet, but with the government as it is, no one knows. I'm going to skip this slide. It's common sense. Don't write it on a prescription pad like that thing showed. Don't write for your friends or family, and I would not have interest in a medical marijuana dispensation. So we need more data. We need that it shows that it's effective in decreasing inflammation, and then better data, on which cannabinoids, how do you deliver it, that sort of thing. Briefly, because I've already gone over, and Andrew's going to be upset. Curcumin, there is a bit of data here. It's a spice. It's used quite commonly. And there have been studies. There was a randomized controlled trial of induction of remission in mild to moderate UC failing 5-ASA, so complementary, and a randomized controlled trial of remission in addition to sulfasalazine or 5-ASA, again, positive and complementary. Adverse events here, as opposed to marijuana, minimal, might be some mild bloating and nausea. That's not uncommon. Typical dose in these studies was about 2 to 3 grams. And I do talk to my patients about this with mild to moderate UC, if they're failing 5-ASA or if they're looking to try something before moving up to a biologic therapy. Again, it's a, let's try this. If it doesn't work, then that type of thing. Call me in a couple weeks or come back in a couple of weeks. Just so you see it, this is, I'll go quickly, this is the induction of remission slide. You can see here 1.5 grams twice a day versus placebo, and this is the maintenance of remission data. I'll leave this for you to view later.
Thank you very much. So as Adam says goodbye, I say aloe, and we'll talk about aloe vera. So aloe vera is a plant. It is a stemless, drought-resisting succulent, which sounds really terrible. But it's actually quite nice to look at, as you can see from the picture there. It's been used for thousands of years across the world for medicinal purposes. And there's a lot of animal evidence, whether it's in vitro or in vivo, to suggest that it has anti-inflammatory properties. The take-home point for aloe vera, and I'll show you the randomized controlled trial in a second, is that it's worth a try, a bit like what Adam mentioned with the curcumin. In those patients who maybe have milder sort of disease, this is UC data, who are not willing to do traditional therapies. So here's the study. It's 44 patients. It was out of Bart's, I think, in London. Randomized, 100 milliliters of aloe vera gel extracted from the leaf pulp. They were given this for 4 weeks, and then it was compared to placebo at that time point. The primary endpoint was remission, defined by a simple clinical colitis activity index at 4 weeks. And you can see that although it didn't meet its primary endpoint, the aloe vera group did better across the board. And it was statistically significant in what they called response, which was sort of a composite endpoint of remission and improvement. So that was aloe vera. Low-dose naltrexone, I have to bring up some of the original studies were done at my institution before I arrived. It's something that in my area, especially of the country, people ask a lot about. Naltrexone antagonizes the opioid pathway. In fact, it's used as a treatment at higher doses for opioid dependency. And the thinking behind it is that endogenous opioid peptides can promote inflammation. And so there was a couple of studies that were done. This is one of them, a randomized controlled trial done by Jill Smith. It was 34 adult patients with Crohn's disease, and they looked at 12 weeks, and the primary endpoint was response based on CDAI. And they met their primary endpoint in this study of 34 patients, 80% to 40%. That was statistically significant, and there was some endoscopic improvements as well that was also significant. Remission rates were higher as well in the LDN group compared to placebo, but this was not statistically significant, and it was well tolerated. However, You have to remember that this was a small study. We need more data. Again, in my area of the country, there's a lot of advocacy for LDN. People come looking for it. Personally, I think we need more data before I would prescribe LDN. I have some patients that I inherited that are on LDN, and I would say most of them have succumbed, if you will, to more traditional approaches after the disease progressed. And some patients, frankly, left my practice when I wasn't that thrilled about continuing to prescribe it. Probiotics, they're ubiquitous in GI practice. There's alterations or differences in the microbiome, and that might play a role in IBD pathogenesis. We know that the microbiome in IBD patients is different than those without UC or Crohn's disease. And so probiotics, which I like to think of as friends with benefits, they're live organisms that you administer to patients, and hopefully you get, again, some benefits. They're safe, and they're not a lot of downsides, except on occasions they can be quite costly. The take-home for the information I'm going to give you next is that for probiotics, they're worth a try for pouchitis. For ulcerative colitis, perhaps not. And for Crohn's disease, I would say no. So I'll kind of whiz through this data kind of quickly. But VSL number 3 is the most widely studied. It's a patented, commercially available probiotic. And there's 8 different strains of bacteria in there, high doses. And it's been looked at to prevent recurrent pouchitis. This is after the pouchitis has been put into remission with antibiotics. And so a couple of studies here for you to look at, and they were quite impressive, and this is non-US data. Out of the Cleveland Clinic, they did an observational type study, a more real-world kind of look in many ways at what happens to these patients. And in this study, at about the 8-month time point, they didn't find VSL number 3 to be particularly effective. A lot of people had stopped taking it for various reasons, lack of efficacy, side effects. There's also some suggestion, especially from this study, that you might be able to prevent an initial episode of pouchitis after an IPAA construction compared to placebo. That's pouchitis. Ulcerative colitis, the data's not very impressive. There's a randomized controlled trial that did have an improvement in a disease activity index score and remission rates. However, there's been a couple of sort of systematic reviews, meta-analyses from our Cochrane friends who said there's insufficient evidence to support the use of probiotics for ulcerative colitis, whether it's induction or maintenance of remission. There was a recent review that I just looked at which kind of teased out just VSL number 3, and again, this was a meta-analysis as well, and this said that VSL number 3 might be effective in inducing remission in UC, but again, in my eyes, not that effective for ulcerative colitis. Crohn's disease, the data is even worse. They've looked at it for induction, maintenance. There's been meta-analyses, didn't show any benefit. In the post-operative setting, there's a study which is randomized that looked at VSL number 3 versus placebo for post-op prevention. 90 days, no difference in endoscopy. 1 year, no difference in endoscopy. Interestingly, there was lower mucosal inflammatory cytokines in the VSL number 3 group. Moving on quickly to diets. Patients are always asking me, what should I eat? I give them wishy-washy sort of advice. They don't like that, but it is what it is. And I do sort of sit them down and I say, look, there are certain foods that we think increase the likelihood of a flare or disease relapse. I'm talking about red meat. I'm talking about processed foods. I'm talking about alcohol, all the kind of things that I like, so I'm probably going to develop Crohn's sometime soon. On the flip side, though, fruits, vegetables, they may be good at preventing the development of IBD. And people have looked at various diets. We'll start with enteral nutrition. That can be exclusively enteral, or that could be partially enteral. And the idea is that you're decreasing the antigenic load to the gut. And it may complement traditional Crohn's disease therapies. In the pediatric literature, there's some evidence that this can be effective. In adults, though, the results are more variable, and a lot of that maybe has to do with just poor adherence in adult patients. Along the same lines, restrictive diets, if you will, also can potentially decrease the antigenic load. Gluten-free diet, patients with IBD can certainly have gluten sensitivity or frank celiac disease, but a lot of our patients are looking to cut out gluten from their diet and try these diets. And a lot of patients, I have to say, I would agree with this study that they do feel better. So know that people are trying gluten-free diets for IBD. The specific carbohydrate diet, I won't go into the details, but there is some data, or there are some data that suggests that it may reduce symptoms, it may reduce some bowel inflammation, but these are really small studies. Case series, if you will, 7 patients, 10 patients. It's hard to adhere to this diet long term, and while it's unlikely to hurt in general, there's a potential for nutritional deficiencies, including vitamin D. FODMAPs. So a low FODMAP diet has been looked at, especially in IBS, and it may help with functional gastrointestinal symptoms in IBD with patients who have overlapping IBS. It doesn't seem to help inflammation. FODMAPs are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, and basically those get to the colon and through various mechanisms can cause symptoms. So by eating a low FODMAP diet, you might help again with symptoms, but not necessarily inflammation. And this is a type of prebiotic approach, if you will. So my take home for diet is that whatever you're looking at, whether it's enteral nutrition, gluten-free, specific carbohydrate diet, low FODMAP diet, it's complementary, but it's not really an alternative option in my eyes. Moving away from diet, or perhaps not, people actually eat pig whipworm eggs. You can YouTube this, it's pretty unbelievable, but it was based on actually fascinating epidemiologic observational data and then some open label trials. There have been some sort of more recent phase 2 type studies in both Crohn's and ulcerative colitis. Crohn's on the left, I think this is Bill Sanborn's study. It was well tolerated. That's all we can really say from that study. There's been a couple of other randomized control trials too, where it doesn't seem to be helpful, but again, seems to be well tolerated, surprisingly perhaps. In ulcerative colitis, there's one study by Summers, which is on the right, 54 patients. There was a benefit in terms of response that was significant statistically, but there was no differences in remission rates. Cochrane folks, again, weren't overly impressed at this time point and sort of said we need more randomized controlled trials. This is a nice table that I'll just skip through. We didn't get to all of these things, but this is Adam's paper from Gastro. It's very nice. When should we use CAM? Why should we use it? Well, I'm okay sort of thinking about using it in patients who want to use it, and frankly, I'm not going to be preventing them from doing that. But if it seems reasonable and they've got mild disease, they're not that ill, if they're thinking about stepping up but they're not quite there yet, then it might be worth kind of exploring that with them. And it builds credibility in terms of the patient-physician, patient-provider relationship. And again, as Adam mentioned before, you might get some buy-in. You might lose the battle by agreeing with your patient to explore some of these things, knowing that they probably won't work. But if you set certain criteria or parameters and you follow the patient very closely, if and when the CAM fails, then you can go to more traditional agents. What's the downside? A bit like we mentioned before, there's potential for contamination. I read case reports of human placenta, bat excrement, in addition to mercury, arsenic, and lead. Side effects are not often reported, but the ones that are can be often devastating. And importantly, we know it can delay effective therapy. Here are the take-home points. CAM use is common. You should ask your patients about it. The studies are small, as we mentioned. There's some evidence of VSL number 3 in pouchitis. As we went through in a lot of other situations, that's not the case. We need more data. The bottom, fish oil, which we didn't talk about, great study by Brian Fagan, EPIC 1, EPIC 2, over 700 patients. We actually do know that sort of fish oil is not helpful for maintenance of remission in Crohn's. So I'm going to finish with a cartoon here, a couple of cartoons, because I've changed my way of thinking about complementary and alternative medications and strategies a little bit. So first, the patient's perspective. This is a doctor sort of saying, we've exhausted all conventional measures. One last desperate option is to put you all on alternative medicine that has a 96% success rate. And I think patients kind of think that we're hiding something from them sometimes. On the flip side, though, this is how I used to think about complementary and alternative medicine. It's like, which way do you want to go, pal? If you want to go down that path to the right, you're going to the graveyard. If you're going the other way, you're going to the hospital. So those are sort of extreme perspectives. But I've come a long way, and so now I'm a lot more open-minded, I guess, with my patients, and I certainly ask them about it, even though, again, the data is sort of scant, but we have a conversation and we sort of go from there. Thank you very much.